Hi, everyone. Welcome to another edition of Clinical Conversations. I'm Lisa White. This is Dr. Greene. How you doing, Dr.
Hey.
Greene? Good to see you. Thank you for doing.
Great to be seen.
Thank you for joining me for this topic today, which is all about transferring 1 or 2 embryos. This is a question I see out and about. People would love to know, is it better to transfer 1, someone to do 2? Can you kind of share, open up?
Well, first of all, just as one point of full disclosure, and we're always supposed to identify our own biases. And you and I have both talked about our own experiences. When I was going through this whole process with my own partner, I had a tremendous fear of twins, okay? One and done was always my mantra. And so I've been in this since 1995, and even in the days when a lot of people were transferring 3 or 4 or 5 embryos, I was a big advocate of doing 1 at a time, and even chose that path when I was going through with my own partner, much to the dismay of the people I was working with at the time, because my wife and I were of an age that they wanted us to transfer more. But today, especially, I think we've got a tremendous amount of data supporting and advocating for 1 embryo at a time, unless somebody really wants the responsibility of twins and is also really willing to accept the risk of twins, because success rates being what they are today, the old strategy of putting in more embryos because they're not all going to implant. If you're seeing someone that still follows that philosophy, then you ought to consider doing things a bit differently.
Yeah, I know with your clinic specifically, you advise transferring usually 1 embryo, correct?
Correct. Yeah. At our center, we typically have live birth rates of 70 to 80% with each embryo transfer. And last time we reviewed, 89% of our patients agree to 1 embryo.
Is that after PGTA or before? Are they PGTA tested embryos or not?
The vast majority are. Probably about 95% are. Okay. And most of our patients agree to single embryo transfer. We are willing to put in 2 at our center. And honestly, the national organization calls what we do elective single embryo transfer, which implies that it's more unusual to put in 1. We're trying to change that way of thinking. If anything, it should be elective dual embryo transfer for people that want to and insist upon having twins. But we don't ever do more than that. If someone wants 3 or 4 embryos, we politely tell them we're not the center for them.
Is there a standard, like in your industry, as far as a recommendation for across? I don't know if you can answer that. Centers?
Yeah.
Well,
there are national guidelines, but it's not even a guideline. It's more of a formal recommendation that talks about how many embryos, and it's based on the patient's age and the prognosis and the success at your center. And so if you're at a center that has a very high success rate, you got to be very, very cautious about putting in more than 1 embryo. And whereas if you're in a center with a low success rate and you have an older patient that has a poor prognosis, national guidelines allow people to put in still 3 or 4, occasionally 5 embryos today without breaching the guidelines. We don't do that because our success rates are very, very high, and that's very dangerous.
Yeah, it seems really kind of unethical. I don't know, like to transfer again 3, 4, 5.
Well, again, it's based on statistics. And, if you're statistically at a center that has a very low success rate and you're a patient that has an individual, anticipated low success rate, the statistics can sometimes justify for people to consider doing some of those things. But like I said, we think that a more proactive or progressive way to think is to raise each center's statistics up to the level where everybody should be thinking about 1 embryo at a time and occasionally 2. But that's our philosophy, and not every center follows that same, way of thinking.
Thanks for sharing that. So the data behind transferring one embryo over two, the implantation success at your clinic is, you said 70 to 80. What was the percentage?
70 to 80% pregnancy rate with one embryo.
Yeah.
When we put in two embryos, the success rates literally only go up by a few percentage points.
Okay.
But here's where the risk comes in.
Yeah.
When we put in one embryo, the risk of twins is roughly about 1.6%, or if you want to round up, you could say 2%.
The risk of
And
twins.
that means that about 2% of the time when you put in one embryo, that embryo splits and someone gets identical twins. Okay. When you put in two embryos at a high performing center like ours, the pregnancy rate goes up slightly, but the chance of twins gets closer to about 68%. And the chance of triplets or even quadruplets becomes around 4 to 5% because either or both embryos can split.
Oh, wow. Yeah.
And so, the point is that, there is greater risk of putting in more embryos. And we always look at what we call the risk benefit ratio. The fact that the chance of a pregnancy rate goes up only slightly, but the chance of a complicated pregnancy goes up substantially, that we feel that the risk is greater than the benefit. But there are some people that really want to have twins, that can safely carry twins, and that are willing to take that risk. And as long as, they're an acceptable candidate, and we base that based on that patient's health, as well as the clearance of their OBGYN, because we don't take care of the second half of pregnancy. So we have to make sure that if we're going to initiate a pregnancy that's going to have two babies, whoever's going to be taking over that pregnancy for the remainder beyond the first trimester has to feel they could safely get that patient to the finish line.
And the factors that you're looking at when someone is looking at trying to have twins or transfer two embryos, you're looking at age, diagnosis,
Yeah, we're looking at their age, we're looking at their overall health, we're looking at their body habitus. What I mean by that is that people that are obese have a higher risk of twin pregnancies for multiple different reasons. It could be much harder to monitor the babies because of a patient's larger size. It could be associated with a higher risk of miscarriage and blood pressure problems. It could also be at a higher risk of a surgical delivery in people that are obese. Ironically, the problem can also be greater at the opposite end. People that are extremely thin or extremely fit might not have enough reserves to carry a twin pregnancy. And so it could be problematic at that end as well. So it's age, it's overall health and wellness. It's also, their ability to get through to delivery, as well as what the risk of a surgical delivery might be.
Okay.
Because twins are at a much higher risk of a C-section rather than a vaginal delivery. And sometimes that, believe it or not, sometimes that's not even the choice of the doctor. Sometimes it's a choice to the hospital. There are some hospitals that will not let people try to deliver twins vaginally because of the risk of the second baby. They always have to have an anesthesiologist in-house if someone has twins in labor because of the high risk of needing to convert to a surgical delivery. And so some hospitals, depending on malpractice in that state and that location, they might say, we will not deliver twins vaginally here.
Okay.
At least not planned. I mean, if someone comes in labor, sometimes they do what they have to, but they won't plan on a twin pregnancy to deliver vaginally.
Okay. And how often does one kind of not make it, would you say, when you transfer?
Well, it depends on where you define not making it. A substantial amount will miscarry in the first trimester. And depending on how early you do the ultrasound, you might not have even known you had twins if you didn't see the early ultrasound and then see that second gestational sac disappear. So there is a higher risk of miscarriage. Believe it or not, there's newer data that, if you want to get really technical, that the way the woman's immune system could further complicate pregnancies with twins. So that there's some newer data that, for instance, if someone is using, for instance, an egg donor,
Uh-huh.
that person might be at a much higher risk of failure if they put in 2 embryos from an egg donor than 1 embryo from an egg donor. And this is because of the way the maternal immune system responds to certain immune components within the embryo. And if an embryo is created with an egg donor and their partner, there's a lot more potential for a misalignment than an alignment. Specifically, there was a study recently that looked at pregnancies with egg donors, and women with certain immune phenotypes might be twice as likely to have a live birth if they put in 1 embryo from an egg donor than if they put in 2.
Wow. So keep those immune systems strong and healthy, right?
Yeah, well, but it's not just strong and healthy. You know, it's kind of interesting that for many, many years, it was thought that you had to suppress the maternal immune system to receive an embryo. And there are some people that would use steroids to try to suppress the maternal response. What we understand today is that the maternal immune system needs to actively help the embryo create a good placenta and good blood flow early in the pregnancy. And if the immune system is too suppressed and is not able to facilitate that implantation, it creates a higher risk of either miscarriage or problems with the mother's blood pressure in the 3rd trimester.
So we'll have to maybe do another talk about that.
Yeah, it gets really complicated. And I can tell you that it's something that even a lot of reproductive endocrinologists don't follow the immune research as much because it is so complicated. And it's not the least bit intuitive. You know, to tell someone that's using an egg donor that if you put in 2 embryos, you might have a much lower chance of a live birth than if you put in 1, their eyebrows go up. And what's that based on? But there's studies that have been published literally over the last couple of months that have shown this in very, very eloquent ways that it's becoming more and more accepted that the immune system has to actively embrace and support the pregnancy.
Okay. A question that was sent in, and I don't know how to exactly word this, but can one embryo ever pull down another embryo? If you transfer 2,
Yeah, and again, there's sort of a dual function of things that are going on because, you know, sometimes a stronger embryo can actually help a weaker one. Okay.
So
for lack of
can you share that? I think that's so.
Well, no, this is where I use the analogy of bicycle riders and a hill coming up, okay? If you have 2 bicycle riders and one's a really strong rider and one's a weak rider and they see a hill coming up, chances are the strong rider is going to make it to the top of the hill and the weak one won't, okay? Ironically, if they're both on the same bicycle, they're both going to make it to the top. And the point is that each embryo and their success has to do with how functional their placenta is as well. And sometimes if one embryo has a stronger placenta than the other, it can actually help by producing certain growth factors and things that can help the weaker embryo. But now that we understand that the mother's immune system is also involved, if these embryos, if one has certain immune phenotype and the other has a different immune phenotype, then the mother could actually have a negative reaction to the entire pregnancy and the whole pregnancy can get rejected. So again, it's a far more complicated interaction than just stronger embryo helping a weaker embryo, because sometimes the maternal immune system might actually shut down a twin pregnancy with greater, you know, predictability than it would shut down a singleton pregnancy.
Okay.
You know, and again, thinking of it this way, you know, from the immune component, people understand if we talk about something that's not pregnancy related, but that people can relate to, people have probably heard of someone getting a kidney transplant and maybe not from a perfect donor. So you take some immune medications to try to suppress the rejection of the kidney. And people are familiar with that. But if you put in 2 kidneys, it's very possible that the immune drugs wouldn't suppress the rejection of both kidneys, because it's a greater challenge to the immune system. So again, 2 embryos could overwhelm, whereas 1 embryo might be accommodated in a pregnancy. Does that make sense?
Yeah, no, totally. I have to ask this question. It's kind of a controversial topic that
Yeah.
an article came out recently from a certain celebrity, Paris Hilton's her name. And in it, apparently she states she's choosing the IVF because she wants twins and she wants a boy and a girl. And I mean, what are your thoughts about that?
Well, I think that respectfully, that's a serious question for her to entertain with her doctor. Okay.
Yeah.
And I think that her doctor and she should be making a private decision, not one that's really guided by the media.
Yeah.
But it's not an unreasonable thing. There are many, many healthy women that could safely carry a twin pregnancy. And I think it needs to be a collective and a medical decision. I'll give you a real world example from my own practice this week. Okay. I have a lady that, based upon her age, she is coming back for a second pregnancy and she has 2 embryos remaining. Okay. And based on her age, she and her OB had a conversation, and they told me that they felt more comfortable with her having 1 twin pregnancy than a second pregnancy now and a third pregnancy 3 to 5 years from now. Okay. Based on just her age and her health status. It may not have been what I recommended, but I was willing to accept that because, like I said, I feel I could safely initiate the pregnancy and get her through the first trimester. But I think it's important that her OB has that confidence that they could get her from the from the first trimester to delivery safely. And so sometimes these decisions need to be made collectively. And sometimes it's not one person alone that says, definitely don't do this. But this is an example where I said, okay, I'm a little hesitant, but I'm willing to do it because that's what you and your OB have decided. And I respect that.
No, I respect people's, choices, but I feel like, obviously, like people like us, we needed IVF due to certain circumstances. And I don't know what her Paris Hilton's circumstances are. If she's having fertility challenges, like hopefully she's getting those addressed. But it sounded like to me that she's just choosing it just because, she wants twins, a boy and a girl. Like, you oftentimes can't choose the gender. Sometimes you might get all boys. You might.
Well, let me just play devil's advocate because, we do often, for instance, I've had situations where clinically someone is coming to me and they want to do IVF, but they want to use a gestational carrier. Okay. So someone else to carry the pregnancy.
Yeah.
Or they want a twin pregnancy and it's for reasons that are not medical,
You see that often? People come here?
Well, I wouldn't say often, but we do see it happen.
Okay.
And I really support a woman's right to choose, because sometimes it's a career decision. I'll give you an example. One of the patients that I had that wanted to use a gestational carrier, she's a bathing suit model, okay? And she thought that pregnancy could change her body in a way that it could limit her when she's at the peak of her career. Who am I to tell her that that's not an appropriate reason to use a gestational carrier? Now, I have another patient that's a very high-performing executive leading a company. She says, I don't have time to take off for 2 pregnancies, but I want to have 2 children. Is it appropriate for me as a man to say, you need to put your career aside and put your all of everything into doing what has traditionally been believed to be acceptable? The answer is no.
Right,
so I don't know Paris Hilton and I don't know what her career decisions are, but sometimes there are reasons beyond the obvious medical ones that might support something that is less than typical, and
frustrating for a lot of people who, the media reporting these kind of stories when people who truly have fertility challenges, they rely and depend on this to help them grow their family, start a family. And it sounded like very kind of elitist, privileged, like I'm just choosing because I get to choose, I want to have twins.
Well, and it might be that, and that is not right. But sometimes, again, as fertility patients, we tend to look at the world through the lenses of fertility patients. But think of it as the reproductive rights issue. I have some women that are freezing eggs or embryos now because it's the wrong time in their career to get pregnant. And they want to wait and get pregnant when they're 40 and 40 or 41.
Okay.
And is it appropriate to say, no, you need to take a time out from your career, even though you're on the rise now, just because it's biologically when people have usually had kids?
You're right.
So sometimes it's a reproductive rights issue.
No, that's very true. Thanks for engaging in this conversation.
No. It's like I said, I try to always look at the world from both sides, and try to put my own preferences and recommendations on hold. And that's why, for instance, before I knew that we were going to have that discussion, that one of the first things I disclosed to you is I'm very biased to singletons.
Singleton, yeah.
But it's hard for me if I'm sitting across the table from someone that either they themselves is a twin or they've had twins in their family and they can actually relate to what it was like to be in a household with twins. It's hard for me to tell them that their lifestyle was wrong just because it's not what I would choose.
No, I have a lot of friends too. I'm involved in advocating for fertility and coverage and all of that. And it's interesting with the public's eye, wondering what kind of impression it gives people with fertility treatments. Those who really need it, and depend on coverage, right? In Colorado, we're going to be starting next year with the fertility coverage. Someone that just wants to do IVF isn't going to get coverage for that. You really have to have a medical condition. It's a disease, infertility disease, to get it covered.
But at the same time, we're finding that fertility preservation, which is a choice, is becoming more and more readily available.
I think it's
in other words, I'm sorry.
I didn't interrupt. I'm sorry. I think it's for people like say that have a cancer diagnosis or need.
No. Social egg freezing and social embryo freezing has become a very real. There's many progressive companies. Depending on where you're getting your lattes and your fancy coffees, that person that's making your coffee might have fertility preservation benefits for purely social reasons.
Gosh,
and again,
it's complicated. Because I don't know what insurance exactly is going to cover. I don't think they will just cover it for anybody that just wants to freeze their eggs. You have to have a medical condition behind it, I believe.
No, that's no longer the case. Okay. More and more companies are using that as a benefit to attract and retain employees.
Okay.
And I could tell you that companies like Facebook and Twitter and Google and AT&T and Bank of America and Starbucks, some of these companies are basically making this available because they want to give women an equal opportunity to control their career path and not have to be guided strictly by biological demands. And so technically, it's not a biological reason that a woman that's 32 might want to wait until she's 40. You could argue that it's a social reason, but if she tries to get pregnant naturally at age 40, it might not be possible. Yeah, and so many of these companies are actually using that as a way of attracting and retaining the best talent.
Oh gosh, yeah, it does get pretty crazy with every state has their own kind of laws and coverage. I would love to dive deeper into the Colorado laws because I just don't see.
Yeah, well, then I could hook you up with some people that could do that because I'm not a lawyer. But as someone that is in the field and hears a lot of things from patients, their motivation is not always as obvious as what the public representation of the motivations might be.
Yeah, no, there's a lot we can cover. You're awesome. Thank you so much for taking this time to talk about, transferring 1 versus 2 embryos. It's a hot topic I see people talk about a lot.
Absolutely. And it's great to be able to, tease some of these things out and maybe get people to think about things a little bit differently than what might be the most obvious first impression.
Yeah. Every conversation we have, it opens up more questions. I think
That's why we keep having them.
I know. If anyone does have more questions, reach out to me. I'm Lisa at IVFmanifestingamiracle.com. I'm an IVF mentor and fertility coach here to support you on your path. And Dr. Greene is a reproductive endocrinologist here in Colorado. He can be reached at enhancingfertility.com. We're all here to support you. Thank you, Dr. Greene.
Stay happy.
You too. Have fun on the slopes.
I will.
Bye-bye.